chair.
How are
How
you?
are you? You got the right chair. I see. You got the
Yes.
comfy chair.
This is actually a gaming chair that I got for my
Yeah.
son, but we hijacked it and put it in our office.
Yeah. Well, I don't blame you because I've got one right here, a gaming chair. They're by far the most comfortable chairs out there, I've
And
found.
this chair actually has a motor in it that will massage your lower back.
Oh, really?
Yes. Yes.
Very cool.
But you know what I was
So how
thinking?
have you been?
I'm
You
good. I'm
okay?
good. I was thinking last night actually. It has been 11 years since Louisa and I lived in Boston. It has just flown by.
Is that right?
Yeah. Yeah, it's crazy. We've
11 years, 11.
11 years.
Mm.
And so we're doing very well.
That's incredible. Yeah.
Louisa, we moved to Boston for her to go to nursing anesthesia school. So she finished that and has been
Mm.
a nurse anesthetist since then. But she actually went back and got her PhD in nursing. And so she's now teaching nursing anesthesia at the local
Wow.
college here. So that's fun.
Okay.
Yeah, and we've got two kids, 5 and 9, so they're keeping us really busy.
Cool.
Yeah.
Wow.
How
Well, you
about
look good,
you? What have
John. You
you?
look well. I'm still, working in Boston. And yeah, I've just been doing the same thing for the last 20 years. And before I met you, and then I've just continued to do that. So I am just, yeah, trying to, I'm doing a bunch of, usual what research stuff, clinical stuff, giving a lot of talks around all over the place. Um, and trying to keep out of mischief. Yeah.
Yeah. Now tell me all of the hats that you wear.
Hmm.
So
Well,
yeah.
yeah. So, well, I'm the chief here at Mass General Brigham of the chief of the Addiction Treatment and Prevention Services at
Okay.
Mass General. So that includes Mass General, Brigham and Women, and McLean Hospital.
Okay.
S yeah. And then I am the director of the Recovery Research Institute, of course, that's where I'm doing a lot of research, recovery research. And then few years ago, I founded this National Center on Youth Prevention, Treatment, and Recovery. So that's a kind of a youth-focused national center.
Okay.
So I'm the director of, yep. And then I'm the president of the American Board of Addiction Psychology right now. I
Okay.
founded that going. Yeah, and a few other things, lots of other things I do. Those are the kind of the big ticket, kind of items that I'm responsible for and kind of run and operate. And yeah, so it's good stuff. Yeah, it's interesting.
It
Keeps
is.
me busy. Too
It
busy, yeah.
is. I knew you for a little while before I knew who you were and what you did for a living. And it was
Mm.
it was a revelation because I was aspiring at that time to
Yeah.
go back to school and do more clinically. And I've actually now moved more into education. So I'm at Emory and I'm the director of their education program for the Addiction Center. And
Okay,
we
cool.
kind of
Yeah.
one of our flagship programs is called the Immersion Program, and we bring in healthcare students from across the state of Georgia of various disciplines, whether it's nursing, medicine, counseling, um, and we try to teach them about addiction and in hopes to
Mm.
decrease stigma, increase knowledge,
Mm.
skills, and abilities, and hopefully bridge the gap for people that
Mhm.
aren't getting connected to treatment. Um,
Right.
and I use a number of your talking points in that
Hmm.
program. I talk about Project Match. I talk about the Addictionary. I talk about
Hmm.
the real stigma of SUD study that you did. I was looking back. It's been 16 years. You may not even remember that study, but
Hmm.
I quote that study often on the use of language and how
Yeah.
important the use of language is and how it has a direct
Mhm.
impact on treatment, right? Um,
Mhm.
and so I was hoping to pick your brain a little bit about that today,
Mhm.
and kind
Mhm.
of what you're seeing as far as stigma and language and the best ways to address that, particularly among healthcare providers. Um,
Mhm.
but
Mhm.
but I want to start off with a general question. So,
Mhm.
if you had one thing to say to a future healthcare worker with regard to treating addiction or perceptions of addiction, what would you say?
Mhm. Well, I guess, first of all, I think I would say that what do we, when we talk about addiction, are we meaning that the truly addicted proportion of all those with SUD on the spectrum of substance use disorder and how harmful and hazardous use? Um, or are we meaning addiction in the generic sense? We often use that as shorthand, don't we?
Yeah.
Meaning, the whole spectrum. We say addiction. I work in the addiction world, but I think classically, as you know, classically we define addiction as that, impaired control to regulate the impulse to use despite harmful consequences, where people have that strongly impaired control over use, and that makes it kind of this psychiatric illness. Um, so I guess, first thing I would do is clarify, what are we talking about?
Hmm. Yeah.
Are we meaning the whole spectrum of SUD from anywhere from 2 symptoms up to 11? Obviously, someone with 2 symptoms is not addicted per se. They may end up becoming addicted, of course, or they may not. There may be a particular phenotype, a particular expression of the illness that doesn't move beyond that. And we have these different types as well as severity. Um, and then I think the other big ticket item would be, this is a long game. This is a long game. We should be thinking about, yes, acute care, we need to do screening, better assessment, accurate diagnosis, and treatment planning for detox or whatever is needed and stabilization. But then also, what do we do then?
Mm.
How do we gauge somebody if we're talking about sustained remission and long-term stable recovery? Then how do we facilitate that as future clinicians or people working with people with these disorders?
Yeah, so I love how you called out the language there of addiction versus substance use disorder and understanding what we're talking about. And I think you're right. If you're looking at it clinically, I mean, addiction isn't in the DSM, right? It uses criteria for the severity of a substance use disorder. How do you define addiction?
Well, I think I would define it in that the way I just described it, which is really that impaired control over
Yep.
the ability to regulate the impulse to use despite harmful consequences. Um, Another kind of classic definition I heard along the way, which is impaired control over a reward-seeking behavior
Mm.
from which harm ensues. Um, so that's another way to think about it. It's that what we classically, I think, culturally, by default, where we go when we talk or hear the word addiction, we think about that person who can't stop no matter what. They're really a slave to the substance. They're hooked on it. They're preoccupied and occupied with it.
Mm.
And it's that abnormally high priority that drug has taken in their life. It's the top priority of their existence. It was never meant to be that, but it becomes that, of course, over time. It becomes the top priority above everything else, above family, above work, above health, above all the things that people normally value. This bumps them out the way, and it becomes highly, people talk about hijacking the brain. That's kind of a good metaphor for what happens. People don't intend that to happen, of course. They start using, and they're getting, the pleasure, the joy, the camaraderie, oftentimes, of the substance involvement. But then over time, it starts to get worse. So, yeah, so I think it's, and of course, And this is where the confusion, I think, comes in the spectrum of substance involvement and impairment, is that when we're talking about addiction, we're really talking about that severe type of substance use disorder in DSM-5 nomenclature. It's the severe end, where it truly is, even though the whole spectrum from 2 to 11 symptoms, of course, means that you are classified in that category of substance use disorder. If you meet 2 or if you meet 11 symptoms out of 11, you have SUD, you have some kind of substance use disorder. But there's massive heterogeneity across that degree of involvement and impairment, right?
Right.
And so, like I said, I think the way I think about it is, to be classified as a psychiatric illness, it has to be involuntary.
Mm.
Just like major depression or OCD or PTSD, people don't want to have those symptoms. They're not having, they don't want to have any of those symptoms. And the same way, people with addiction, severe substance use disorder, are really using against their will. They try and cut down and stop, but they're unable to do so. In other words, we classically think about loss of control. It's really impaired control, and in some cases, very severely impaired control.
Oh, wow. Okay.
To the point of their own, obviously, losing their own health and life. So yeah, so I think it's, I think a lot of it has to do with in my mind anyway, I would say that addiction is that loss of control, or that radically impaired control, where people are, again, they're trying to cut down and stop, unable to do so. They're using against their will. It's involuntary, and that's why it is a psychiatric illness. That's why it is. It wouldn't be in the DSM-5 if it was voluntary, and people were just choosing to, it doesn't make it a psychiatric illness. What makes it a psychiatric illness is that people are using against their will. It's kind of, the train has left the station. It's built up such momentum that no matter when they put the brakes on, they just can't stop that locomotive.
Right. You mentioned earlier about you used the word phenotype, right? And when I hear that, I'm thinking, okay, you're talking about biological susceptibility that a person has, perhaps from birth, to developing a substance use disorder, particularly the severe addiction, right? What, I think about dopamine, and I think about the someone born with perhaps a deficient or dysregulated dopamine system. Is that a big part of it? Are there other genetic markers or things that you've seen that make someone kind of more susceptible?
Yeah, well, it's certainly that. It's certainly genetics and epigenetics. In other words, the genetic loading plus the environmental exposure over time during those first couple of decades of life in particular, right? Which are going to determine what genes get turned on and turned off. So that's kind of what we call epigenetics. And those environmental exposures, it could be stress, trauma, early exposure to the substance, particularly in the early teens, for example. Early exposure all have effects on the genome, on the genetic makeup of the person, so that it can exacerbate risk over time. So what we call epigenetics. So this is why, of course, that psychiatric illnesses in general and SUD, substance use disorder, is in that category of what we call complex illnesses. In other words, it's not one thing. Yes, genetics does independently increase risk 4 to 8-fold, an independent risk factor. But it doesn't mean you're going to get the disorder if you have that genetic predisposition. You have to have those other kinds of ingredients to make the cake. You can't just make it with one ingredient, So you need all these other risks present, including, of course, access to the drug itself.
Right.
You got to have access to the drug. And some people just don't have access, so they're never going to get a cocaine use disorder because they're never around cocaine, they're never exposed to it. So you have to, that's why we have so many more, alcohol use disorder patients and individuals, just because you can get it. You can get it everywhere, and it's easy to get. It's ubiquitous, etc. Yeah, and so you've got these, you've got the kind of the developing risk in that trajectory over time, but then you've got the different expressions of the illness, right? So you have one dimension is severity. So you go up from, you get into the category of SUD and DSM, and then you might start climbing up that ladder, if you will, of symptoms into mild, moderate, severe. Some people will progress up through that hierarchy of levels up through severe addiction, but some people don't. Some people actually stay in the mild category and they never progress out of that mild category, or they're in the moderate category and they never go out of that moderate category. And not only that, not only are those kind of different phenotypes or different expressions or different types of the disorder that never progress, but there's other kinds of ways that the disorder presents in those people at the same level of symptoms. So you might have two people at a severe end or two people at the moderate, but very different expressions, the way it impacts their life, and the trajectory of those particular forms of the disorder. And this what makes it very difficult to treat with one thing, because it's so heterogeneous and it's dynamic. It changes over time. And it has different manifestations depending on when you are, who you're seeing, whether you're seeing an adolescent or a young adult or a middle-aged adult or an older adult, a man or a woman. All of these things make a difference. Their life context, do they have a lot of recovery resources and other kinds of things at their disposal versus somebody who's very impoverished with no education, no employment, living in, so all of these things matter. They matter in terms of the expression, the impact of that form of the illness, and the dynamic aspects of it. In other words, how all that impacts and changes over time. There's different models of psychopathology and ontology in terms of human development, but I like the kind of Gottlieb. There's a guy called Gottlieb from many years ago now, but you might have come across him. He talks about this, that it's the human development is an epigenetic psychobiological dynamic system. Now that covers it all.
Yeah.
You got the epigenetic psychobiological dynamic system. So that's true. In other words, we're affected, of course, by everything, from the genes, the genome, the psychobiology, the psychology, the biology, the mind and the brain, the software and the hardware. And then you've got the social environment, the policy environment, the access to substances. The cost of substances also impacts consumption, which influences risk. All of these things, of course, and it's a dynamic and it's a system, as he talks about. That covers it. But of course, the question, of course, is, we know that everything affects everything else at some level, but what's the most important things that we can actually do something about?
Yeah, a lot that I could unpack there. But as you were sharing earlier, I thought about, you mentioned age of the onset of use, the first exposure to the substance. And so my wife and I are both in long-term recovery and from severe substance use disorder. And we have two kids. We have a 9-year-old son and a 5-year-old daughter. And we often joke that we're not saving for college, we're saving for rehab. And, I can't help but look at them kind of mindfully, right? As far as, okay, what are the little subtle things that I might be seeing in them, right? That could be risk factors. Like my son, for example, he's very sensitive, and he can be very emotional, which also is a great benefit for him. He's so empathic and he's so kind, but he's got big feelings, right? And you know, I think about that and I think, oh man, this could be a subtle kind of risk factor. He loves devices. He can get sucked into a device, right? He also loves sweets, right? Same thing with video games. He can get, locked into them. And so I'm curious your perspective, if you have any suggestions as far as, okay, knowing that he already at birth has a what, 3, 4, 5 fold increased risk. What can we do to try to buffer? One thing that we do, I can tell you this, is we're very honest uh, about
Mhm.
our history. Um, and so we try to make it known that this is present in our family. But I'm just curious your thoughts.
Yeah. And it's a great question. Um, and there's a lot of talk about, well, not even say a lot, there is some talk, not enough talk, probably about breaking this into what they're calling the intergenerational cycle of substance use disorder from parents to offspring. And um, and so you raise an important point, and what can be done. I think one thing is that, you and Louise are obviously you are role models, of recovery, and you talk about it. You manifest, you're living a life in recovery. Um, and that's, fantastic. That could not be better in terms of, diminishing risk, that your kids will, they know and hear and see that you are people in recovery. You've had these disorders in the past, you now live in recovery, and you'll, no doubt, you are educating them and letting them know about it to the extent that they can understand it. And when they're able to understand it, to be able to talk about that with them and their risks for these onset of these disorders. The other kinds of things that, what you alluded to, John, reminded me of this notion of what they call endophenotypes. I talked about phenotypes, we talked about phenotype, the different expressions. And endo means kind of in the middle, it's kind of like intermediate phenotypes. So it's kind of what are these intermediate risk factors that may lead later to the expression, the full expression of the illness. And some of those things we started to identify that have a little bit more robustness. Things like impulsivity, sensation seeking, these kind of personality traits, that inability to delay gratification. So if people are a bit more impulsive, they have that stronger impulsivity trait where they can't delay gratification. That's a risk factor, but it can be modified.
Sure.
So these things can be modified when you see, these externalizing behaviors, so-called. You've got internalizing and externalizing behaviors. Both can elevate risk. These internalizing symptoms, anxiety, depression, as well as externalizing kind of oppositional defiance, sensation seeking, these novelty seeking, these kinds of personality traits have been associated and implicated with onset because they elevate risk and exploration, of course, exploration, impulsivity, and sensation seeking, novelty seeking. They're all about going out and exploring the world. So in many ways, they're good things. On the other side, they can lead to risks and hazards and so on. So depending on the environment that you live in and to which the kids are exposed, that will either diminish or elevate risk, and how you shape those traits, those endophenotypes. So they're not specific to substance use disorder. They don't have that direct link, but they elevate risk like many of these other things. They're not specific, but they elevate risk. And then when you get a number of these things converge, then you can get that manifestation of the disorder.
Yeah, and you mentioned impulsivity. So when I was 13, I was diagnosed with ADHD
Mm-hmm.
and very impulsive, continue to be very impulsive, hyperactive, inattentive. And my personal experience and the way that I kind of see the progression of my addiction and other psychological issues that I've had, um, I see ADHD as kind of the first and perhaps the core. Because when I first discovered substances, I mean, well, alcohol was big, but the biggest was amphetamines. And,
Mm-hmm.
the amphetamines was really a treatment for my ADHD. And it really seemed to kind of click and correct a lot of the things that I didn't even know I was missing.
Mm-hmm.
And so I was, luckily, neither one of my kids have ADHD, and neither one of them have major issues with impulsivity, which is nice. But do you see that a lot as far as ADHD and the connection between that and developing a substance use disorder? I know that there's certainly an increased risk, particularly in males, right, with ADHD.
Mhm.
Um,
Mhm.
yeah. So
Mhm.
do you have thoughts about that?
Mhm. Yeah, yeah, definitely. Those so-called externalizing cluster, that would be ADHD, oppositional defiant conduct disorder, that cluster of externalizing symptomatology. Some people would say that, it's hard to really clearly delineate those syndromes at these early stages because those kids, developing so quickly, it's hard to really know what's what. But so some people would say, well, it's just kind of, let's call it externalizing symptomatology, and they've got those clusters of symptoms. Now there is convergence. There are clustering around ADHD, of course, conduct, opposition. There is clustering around them when you do cluster analysis, and those symptoms tend to go together and cluster together. So that has been done. Um, but you're absolutely right. Those all elevate risk. ADHD, opposition to conduct disorder, in particular, will elevate risk. Again, it does not mean that those kids are destined to develop a substance use disorder. It just means, again, they are at elevated risk. So again, it's depending on how you deal with that as a parent or as a school. Or whatever part you're playing in those young people's lives, how you shape those characteristics, those traits, if you will, what you do with them, how you treat them, how you help that person mitigate them and adapt to their environment in the best way possible.
Right. Yeah, no, absolutely. And it's interesting. My kids know our history and have learned that they have this stigma against alcohol. And it's not, we didn't teach them this. They just kind of inferred that alcohol is this bad thing and that anybody that drinks alcohol is bad. And I was explaining to them that it's not alcohol, it's that some people they drink too much and they can't stop. And but most people can drink alcohol and it's not a problem. So I'm trying to explain this to them and they didn't quite get it. We were actually having a conversation this morning about it. And my daughter said, "I'm never drinking alcohol." I had I had a flashback because I remember saying that as a kid, right? I'm never doing that. But hey, like you said, you're developing so fast, you get to a point where that's a distant
Yeah,
memory. Um,
yeah.
but but
It's funny you reminded me. Sorry, we're going to finish your
no, no,
sentence.
no, go ahead. Go ahead.
No, you just reminded me, John, so many people that I have known, you too, no doubt, and you're one of them, it sounds like, who have had, either just said, I'm not going to ever use, or had alcoholic parents, one or both parents, or in their family, had an alcohol disorder, or an alcohol addiction. And they said, I'm never going to drink. I'm never going to drink. I don't want to be like my dad or like my mom. And then they develop the disorder nonetheless. Powerful. It's powerful when you hear people say that they had those stark role models um, of what not to do and therefore not to drink, and yet they still succumbed and did it. Maybe thinking, again, the social pressures, other pressures, and then the genetic factors, of course, that can, the way that genes, of course, can confer that risk is it can make people super sensitive to the pleasurable effects of alcohol. So some people are just they get more euphoria, more relaxation, more disinhibition from alcohol than other people. Other people actually find it more aversive when they drink on initial exposures, just by virtue of their DNA as well. And those people, of course, they think, wow, this is fantastic. They might just say that to themselves.
Oh
This is
yeah.
the best thing ever. And they don't realize, of course, that they're experiencing it in different ways, because how could they? They just think everybody must be feeling this, but they feel it much more profoundly. And of course, that's the hook. And despite their best intentions, that hook is so strong in some people that it leads them into that path. Now, what it seems to be, though, if their parents are in recovery, is that they seem to get into recovery sooner, just because they've had exposure to recovery.
Really?
Yeah,
Wow.
so
Wow.
they tend to have shorter courses of the illness, so they're more likely to get into recovery sooner when they have parents who are in recovery. Yeah.
Wow, that is so promising. And I will take, I totally agree with what you just said. And I will take it a step further because I completely identify that I feel like when I first used alcohol, the effect it had on me was exaggerated from what quote unquote normal people feel. It was such an intense feeling of euphoria. The next thought in my head, and I remember having this thought, was if I can feel this good, why would I not want to feel
Mhm.
like it all the time? Like,
Mhm.
I didn't learn that
Mhm.
anywhere. That I didn't hear.
Mhm.
It was
Mhm.
just in my brain, right?
Right, right.
And it
Yeah.
was like, wow. And for the next 10 years, that's what I did.
Mhm.
And it's the
Mhm.
classic, everything became
Mhm.
compromised. It was the most important thing in my life. And so I can
Mhm.
totally identify with that kind of first
Mhm.
one being just such a powerful thing.
Mhm.
Um,
Yeah.
so and I want to be mindful of time. I wanted to talk a little bit about what you're doing currently with regard to stigma, if anything, right? Stigma
Mhm.
is a big focus for us in kind of the education of these healthcare students. One of the inspirations for that is a study that you did called The Real Stigma of Substance Use Disorder. I think it came out in 2010, and it compared, correct me if I'm wrong, but it compared two groups of healthcare professionals and it gave them an
Mhm.
identical case study. One,
Mhm.
the only difference was one of the patients, the case was referred to as a substance abuser, and one was referred to as having a substance use disorder. And then they
Mhm.
measured perceptions
Mhm.
and various, I'm trying to think of the whether or not they would benefit from treatment, whether or not they would benefit from
Mhm.
punishment, exoneration,
Mhm. Yeah.
attribution, etc.
Yeah.
So I'm, I'm
Yeah.
I'm curious, kind of, to hear from the person who was kind of did that
Mhm.
study. What,
Mhm.
if anything, can you say about that? And has anything changed in the last 16 years, or in the past
Mhm.
16 years?
Yeah. Yeah. Well, it's interesting. Um, you know, it's interesting, isn't it, how in the substance use field, um, how we've adopted that abuse and abuser terminology. You know, the question I often pose to audiences is, you know, people with eating related conditions are uniformly described as having an eating disorder, never as food abusers.
Right.
And yet, with people with substance related conditions, historically, were always referred to as being drug abusers or substance abusers or alcohol abusers, and not as people with a substance use disorder. I have never heard anybody who works in the eating related field described as anything other as working in the eating disorders field, or anybody who has those conditions as having an eating disorder, never as a food abuser.
Right.
Um, Now, so that kind of thought led me um, down that road of like, wait a minute, well, if we're using that abuse and abuser terminology, that seems to imply this kind of volitional, willful misconduct, or
Mm,
potentially could that people who are abusing a substance, like a child abuser, they're doing it, you know, voluntarily. They're engaging in willful misconduct. Um, Whereas if you invoke that disorder terminology, people might think about it more about a medical condition, like we do for eating disorders. There's some kind of medical malfunction that's gone on inside that person that has produced the disorder. Hence, we call it a disorder. Anyway, so you know that's why initially led me to do that study, that randomized study, and then just so happened I was lucky to be able to get access to 600 clinicians, expert clinicians in the mental health and addiction field, to be able to study and expose them to, just like you said, John. Half of them got at random the vignette describing the same person, but using that abuser terminology, and half of them got the description of the person with the substance use disorder terminology. And you're quite right. We saw these differences, systematic differences in the way that people perceived the exact same person, just contingent on what kind of terminology was used to describe them. And then we followed that up in a general population sample, and found even starker, bigger differences in the general population.
Wow.
When people considered the different terminology. So yeah, so it does make a difference. We've since done other studies where we look at different ways of describing these disorders, from the more biological to the less biological, and we look to see whether that makes a difference in terms of stigma and the different dimensions of stigma. So we've looked at that. One of the things that I was interested in, for example, is, if we describe these disorders as being chronically relapsing brain diseases, for example, does that reduce blame more or less than describing it as a brain disease or a disease or as an illness or as a disorder or as a problem? Does it make a difference if we use very heavy biogenetic or biomedical terminology versus less biomedical terminology? And if it does make a difference, on what dimensions of stigma does that make a difference? So I studied a very large sample of the US adult general population. This was a census matched sample of the US adult population. We had 3,600 people in this study, and we exposed them at random to a vignette of a person described as having opioid-related impairment, but they were in treatment and they were learning about their problem or their condition from staff members. And we just inserted we had 6 different levels of the independent variable here. And then there's the same description of this person in treatment with opioid-related impairment, but it was described, they were learning it as being described either as a chronically relapsing brain disease, as a brain disease, a disease, an illness, disorder, or problem.
Okay.
What was interesting, then we asked members of the general public who were exposed to one of these 6 different ways of describing the exact same person in treatment. We asked them, are they to blame? Would you have them as a babysitter or as a marry into your family? Would you, do you think they're going to get well? Will they be able to get well from their disorder and get into recovery? Things like that. So we had a number of different, do you think they're dangerous? So we had the classic dimensions of stigma, are they to blame for their disorder? And what we found actually was very interesting, and it was opposite effects. So depending on the type of stigma that we were measuring. So when we randomly assigned the more biomedical terminology, people who got that vignette describing the opioid impairment as a chronically relapsing brain disease, people viewed that person as significantly less to blame for having the disorder than the same person when it was described as an opioid problem.
Okay.
Conversely, when people who got the chronically relapsing brain disease one, they viewed that person as more dangerous and less likely to recover than the same person described as having a disorder or a problem.
Wow.
And the same was true of things like social distance. So they were less likely to want to have them as a babysitter or have them marry into their family if the same person was described as having a chronically relapsing brain disease or a brain disease compared to having a disorder or a problem. So it does make a difference, but in different ways, depending on what kind of dimensions of stigma you're looking at, right? So the implications, I think, there, John, are that, and I wrote this in the paper, but are that it may matter. We may want to be selective when we're trying to reduce stigma and the different dimensions of stigma. I think, this is what we're not always that aware of, is that there are different subdimensions of stigma, not just blame. Blame is one of them, is a big one. But when we want to reduce blame, that blaming and shaming stigma, that can prevent people from disclosing that they have a problem and seeking help. we might want to use that more biomedical terminology to help diminish that sense of shame and stigma and promote the sense that these are actual medical diseases, medical disorders, which they are, of course, that's factually true, so that we can help people get into treatment sooner. On the other side, though, when we want people to reintegrate back into their jobs and society and moving forward, we might want to refer to that less about them having had or having a chronically relapsing brain disease or brain disease or a disease, but rather that they've had a disorder or a problem, history of disorder or history of an opioid problem or alcohol problem. So in other words, to downplay the biomedical terminology and upplay the other one to diminish their other the perceptions of dangerousness and social distance and other things. So I think that's an interesting implication of that set of findings that we found in the general population in that large study that we did. But a fascinating, kind of set of findings there, the exact opposite depending on what type of stigma we're talking about.
Okay, so when you're trying to reduce shame in a person, right, with a substance use disorder who's perhaps in a position where it would be beneficial for them to disclose to a healthcare provider, that's when you would want to use the medical terminology chronic relapsing brain disease. On the
Exactly.
back end, if we're talking about benefiting from treatment, if we're talking about, are they going to be able to marry into a family, babysit a child, that type of thing, that's when you would want to use disorder or problem.
Problem, exactly. Yeah, the less biomedical terminology. Yeah.
Interesting.
Yeah.
That is really
Because
interesting.
yeah, it really is. Yeah. And it means we want to be, and again, all of these things are true. It's one of relative emphasis. We know that these things, are chronically relapsing brain diseases. They are brain disease. You can see the disease in the brain of somebody who's chronically exposed to these substances, how it affects the brain's neurocircuitry and the tissue in the brain structurally. Um, that's a fact. But again, it's how much do you want to emphasize that when, right? When on treatment entry and getting people, yes, and let's talk about how the neurocircuitry, it's not your fault that you've lost control over this. This is what happens in the brain. And that leads to this impaired control over the ability to regulate the impulse to use despite harmful consequences. This is what we call addiction, of course, and we do know it's a brain disorder. And so to talk about that biomedical stuff, because that helps to diminish blame and self-blame and shame and all the rest of it and get people into, as well as the family. But on the other side, on the exit side, getting back into society again, de-emphasizing that seems to be the better way to go.
One thing I try to do I have the students for a week, and I use my story quite a bit as hopefully a way to decrease stigma because I would hope that they look at me, right, and they don't see someone who is who has an addiction, right? They see someone who is confident, who is capable, who is, happy in all of these things. And I really try to, because I believe this, I really try to emphasize that for me, addiction is the best thing that ever happened to me. It's my greatest asset. If anything, I see it almost as a superpower now in recovery, right? That I actually view it much differently than I did, 17, 18 years ago when I got sober, right? At that point, it was a scarlet letter. It was a gaping wound. But now I truly believe that everything good in my life is a direct result of me being so literally. I mean, my career, my family, um, my passions, everything. And so I really try to kind of emphasize that piece. Because I think we get stuck on the stigma and the shame and the negative when in my experience coming through it on the backside recovery is progressive and it has this ability to really be an asset to a person. Do you see it that way, or has that been in
Yeah.
any way influential in
Well,
kind of your work?
I think, recovering people are a massive, huge inspiration, when they can come. kind of out of the closet, talk about their experience and share that with other people. Because like you say, it dismantles those stereotypes that people have, and it helps to remove and decrease that stigma. The old adage, the mess becomes the message, the test becomes the testimony, the victim becomes the victor, the insight becomes the inspiration. All of those things are true in recovery. That is the story of recovery, because all of those things happen. The test becoming the testimony and the mess becoming the message, like you said, John. And it turns it around, it turns it on its head, where the biggest disaster becomes a huge inspiration for other people. Because you can say, I've been there, I've done it, I've got out from under, and I'm living successfully a life in recovery. And that's a massive visual testimony of what can happen, and that can really help to dismantle those and inspire, of course, not just dismantle stereotypes and the stigma associated with them, but also inspire people to want to make a difference.
Yeah, it's I think it's important. And well, John, I cannot thank you enough for taking the time to speak with me today. You have been so gracious with me over the years. You wrote letters of reference for me to get into graduate school. You've always been there as somebody that I can talk to, even if we haven't touched base in a while. And so I'm so appreciative of your support, your kindness, and all of the work that you're doing in the field. It is just, it's truly, truly amazing. So uh, thank you again. Um, yeah. Is there anything you want to say before we wrap up?
No, I just say thank you. Right back at you, John. It's just so great to see you and to see you doing so well. It looks like it's Christmas every day there with you.
I know.
And so it's great to see. And no, it's just great to see you. And just, it's just what an honor it is and pleasure to talk to you and to discuss these questions, great questions you've asked. There's a lot, of course, to cover in this area, isn't there? We just touched on a few little drops in the ocean here, but important ones, as you said. But yeah, just honored to be here with you, John, and all the best to you and Louisa.
Thank you. Thank you. All right, John, you
We'll
take
catch
care.
up soon.
I'll talk to you
Yeah.
soon.
Yeah. Okay, John. Be well.
Bye.